Good evening, everybody. I'm Stu Bromberg. I'm the CEO of the Jewish Federation of Western Massachusetts, and I'm glad you're able to join us this evening. Tonight's conversation, this is a town hall conversation on COVID-19. Um, COVID-19 has been a major part of our lives for the past year, and although some things are changing, we all still have a lot of questions. And that's the purpose of our presenting this program this evening. I'd like to introduce our guest speaker. Dr. Eric Granowitz is a board certified infectious disease physician participating at Cooley Dickinson Hospital, an affiliate of Mass General Brigham in Northampton, Massachusetts. He is director of antimicrobial stewardship at the hospital. Before coming to Cooley Dickinson, he was an associate professor at Tufts University School of Medicine, where he was on faculty for 30 years. Dr. Granowitz also teaches in the Physician Assistant Program at Springfield College, where he was named Clinical Instructor of the Year in 2009 and in 2020. He received his medical degree from Columbia University College of Physicians and Surgeons. This is his 25th year as a member of the congregations Kodemo and B'nai Torah. Rick is a former synagogue president and has chaired its Chesed committee for over a decade. And tonight, as I mentioned, we are asking that you submit your questions through the chat function. And we have Dr. Scott Siege, who is going to be moderating those questions and presenting them to Dr. Granowitz. Scott is a medical director at Quabbin Pediatrics in Ware, Massachusetts. He's a general pediatrician and he lives in Amherst, and Quabbin Pediatrics is a Bay State hospital affiliate. So without anything else right now, I would ask Dr. Granowitz if he would share his screen so that we can begin the show and see this presentation. Thank you.
Okay, good. Can everybody see my slides? Fantastic. So first of all, I'd like to thank Stu for this opportunity. I'd like to thank Michelle for facilitating this, and I'd like to thank Scott for moderating. Okay. I see a lot of friendly faces, familiar faces in the audience. It's nice to see you. I'm hopeful that by virtue of this talk, we'll be able to answer questions people have about COVID, in particular about the vaccine, and hopefully make people feel more comfortable about receiving the vaccine, because that's really our goal tonight, is to make you feel comfortable so that you're going to go get vaccinated when the opportunity presents itself for you. We're going to start. I'm going to present slides for about 15 minutes, and then we'll have questions. So first of all, just a little background. The name COVID, or COVID-19, comes from the CO of corona, the VI from virus, D from disease, and the year 2019, which is when the virus was first described. So that's how we get COVID-19. The virus that causes the infection actually has a different name. It's called SARS-CoV-2. So this is the virus and COVID is the disease, kind of like HIV is the virus and AIDS is the disease. We've known a lot about coronaviruses for many years. Here's a picture of them. You can see here circular, and off of the virus, there are these spikes. And it gives the virus actually appearance of a crown, and corona means crown. There are 7 coronaviruses that are known to infect humans. 4 of them cause essentially the common cold, but 3 of them have been much more severe. And those include severe acute respiratory syndrome, Middle East respiratory syndrome, and also SARS-CoV-2. These severe outbreaks of these 3 viruses have been characterized by very bad lower respiratory disease. Some of you may remember SARS. It presented in the early 2000s began in China's Guangdong province and affected about 8,000 people and was associated with 10% mortality. MERS, Middle East Respiratory Syndrome, is still ongoing. It's affected about 2,500 persons starting in Saudi Arabia about 10 years ago, and its mortality is quite high, 34%. COVID-19, as I think most folks here know, was first recognized in Wuhan in China's Hubei province in December of 2019. Just a very quick timeline for the beginning of the outbreak. The earliest identified patient was on December 1st. This was in Wuhan, even though looking back now, disease was circulating before December 1st. By the end of the month, China had reported this cluster of pneumonia cases that were associated with a wholesale market. Less than a week later, a Chinese group released the sequence, so in other words, the genes of the virus, so that others could do research on it. And the first US patient presented on January 19th. Interestingly enough, he heard about these alerts and he actually reported himself to a clinic saying, I think I may have this new infection. Here's a photo from the wholesale food market. What you can see is that you have animals, such as here a chicken, here are frogs, in close proximity to each other. You can see that there's a scale here. And so this is really an ideal environment, a laboratory almost, for bringing together viruses from different species. And that allows them to intermix and to jump from species to species. The jump for COVID-19 was probably from the bat, potentially through an intermediary host to humans. The details of this figure aren't important, but I just want to show you how rapidly this epidemic takes off. This shows what happened in China, where cases were negligible in January, and then suddenly within 2 weeks, there were 65,000 cases. Really striking. So what are the numbers? As of Sunday, globally, there were 100 million cases, of which there were about 1/3 new daily, and there were over 2 million deaths. And these numbers are probably significant underestimates because these are confirmed infections. What about the progress? So if we look at how things have done since the early spring, initially you can see in the magenta is the Western Pacific, that's China. But now we see very few cases in China relative to the rest of the world. And we can see that predominantly cases now are in Europe and also, as we all know, the United States, which is now, we are now about 1/4 of the epidemic ourselves. Sad, very sad. Here in the US, the numbers are 26 million cases, of which there are 100,000 new each day. Most recently, these numbers have gone down a little bit, and there have been almost 500,000 deaths so far. But there are many other people who have died from the disease. If you look at deaths in a different way, it looks like this number is probably much larger, in part because some people who have COVID are not diagnosed as such, and also because other people have died because they've been frightened to seek health care. Many people have died at home from heart attacks because they've been unwilling to go to emergency departments because they're worried that they could catch COVID. Here in Massachusetts, and we can see ourselves out here in Western Mass, there have been over 500,000 cases, most recently about 3,500 a day, and there have been 15,000 deaths, most recently about 50, 60 a day. And actually a very large percentage of these deaths have been in nursing homes and other assisted care facilities. What are the symptoms of the coronavirus? The 3 major symptoms are fever, cough, and shortness of breath. Generally, the symptoms appear 2 to 14 days after exposure, but many people manifest no symptoms. I think many people have heard that frequently patients will manifest loss of smell and loss of taste, and that is a real tip-off to the disease. Some patients only have upper respiratory symptoms, like a runny nose, and about 10 to 15% of patients have predominantly gastrointestinal symptoms like nausea and diarrhea. In terms of a large group, Dr. Fauci thinks that about 40% of patients are asymptomatic. About another 40% have a minor illness, which, having spoken to many people with a quote unquote minor illness, you don't feel good. About 20% are hospitalized, of which 5% end up in the intensive care unit, and there the mortality may be up to half. Very sobering numbers. And now let's move on to immunizations. So there are many different ways to make a vaccine, and I'm going to actually start from the bottom and work our way up. So an attenuated vaccine is one where you take a virus and you weaken it, and then you inject that weakened virus into a person. In an inactivated vaccine, those vaccines, which are in development, involve killing the coronavirus and then injecting it. The dead virus can also be broken down into different particles, usually proteins, and they can be injected into people to stimulate an immune response. The J&J vaccine, which should be available soon, the Johnson & Johnson vaccine, actually uses a viral vector called an adenovirus, which causes generally mild infections in people. And what they do is they take part of the coronavirus genes out, they put it into the adenovirus, and then you're injected with the adenovirus. The adenovirus then gets this piece of coronavirus, not a whole thing, but a piece of coronavirus into our nucleus. It does not mix into our genes. And then the DNA from the virus is converted to RNA, and the RNA is used to make proteins. In the vaccines that we're going to talk about predominantly tonight, the Pfizer vaccine and the Moderna vaccine, these are messenger RNA viruses. And what happens is, just to reiterate, there's DNA that comes out of the cell normally. It's then outside, it comes out of the center of the cell, the nucleus, kind of the brain of the cell. It goes into what's called the cytoplasm, which is like the fluid around the brain, but still within the cell. That mRNA then tells the fluid in the cell how to piece together amino acids to make a protein. In this case of this vaccine, the mRNA that comes in the vaccine just goes right into that fluid around the nucleus. That's called the cytoplasm. It doesn't get into the brain of the cell. And the body then uses that to make proteins. These proteins are released from the cell, and they stimulate the body to make an immune response. The mRNA is gone soon, within hours. And so there's no chance at all that you would get coronavirus from this shot. So you're completely safe in that regard. There are other unknowns, but this is not an unknown. This is a known. In terms of the Pfizer vaccine, they studied 40,000 volunteers late last year. The volunteers were over 16 years old and came from many countries. And the subjects got 2 injections 3 weeks apart of either the Pfizer product or else placebo, meaning salt water. The numbers were just dramatic. I mean, I was worried that the vaccines that would come out would not be particularly effective. They might only be 60% effective, but these are dynamite. So of the 20,000 volunteers who got the vaccine, only 8 came down with infection. And that's compared to, of the 20,000 who got placebo, 162 got infection. And that's 95% efficacy. I mean, that's great. Now, the measles vaccine is actually better than this, but this is better than most of the other vaccines we have available now, and really gives us an opportunity to get what's called herd immunity, where we can protect each other. And I'll talk about that in a little bit. Perhaps more importantly than people getting sick is keeping people from getting really sick. So the real goal here isn't to keep people from having symptoms of the common cold. The real goal here is to keep you from being in a hospital, to keep us from dying. And of the 20,000 who received the vaccine, only 1 person got severely ill. And of the people who received placebo, 9 became very ill. Side effects, they're very common. But they're generally not incapacitating. In fact, I would use the word minor, having experienced them myself. So I got the Pfizer vaccine, and I got it on a Monday after lunch. And by dinner time, my arm kind of hurt a little bit. And then I went to bed feeling fine. I did wake up in the middle of the night, had a little bit of a headache. felt a little bit feverish, had a little bit muscle aches. I got up, used the bathroom, went back to bed, and I was worried because I was supposed to go hiking with my son the next day. I was on vacation. And, but I woke up at 7 a.m. and I felt fine. And those are tend to be the reactions that most people have. I actually had fewer symptoms after my second injection, but most people actually experience more symptoms after their second injection. The Moderna vaccine involved 30,000 volunteers, 2 injections, this one 4 weeks apart. They only did adults, so that was only over the age of 18. 11 given the vaccine developed disease, 185 given placebo had disease. And by saying disease, I don't mean that you actually got infected, but you got infected and manifested some symptoms of the infection. There is a difference. So one thing we do worry about is someone who got the vaccine could theoretically infect someone else, not because they had the vaccine, but they got COVID, didn't get symptoms, and then shared it. Dramatically, 30 volunteers had severe disease, but none of whom got the vaccine. Once again, this is really where the money is. You don't want to end up in the hospital, and we don't want to die. And these vaccines are great at that. Injection site reactions and systemic reactions were very similar to what I described with the Pfizer vaccine. The Johnson & Johnson vaccine is an adenovirus vaccine. They had 40,000 volunteers in their study. What's nice about it is it doesn't have to be refrigerated like the other 2 vaccines, and that it's only 1 dose. This vaccine was 66% effective in preventing moderate or severe disease, 72% in the US, 57% in South Africa. This doesn't necessarily mean that this vaccine isn't as good as the other 2, because the virus, as everybody knows, has changed some. However, remember what we're focusing on. We're focusing on people getting really sick. You're either ending up in the hospital or you're dying. And this vaccine, 4 weeks after the shot, was 85% effective. And there were no cases, I repeat, no cases of severe disease seen 7 weeks after the vaccination. Regarding the 2 vaccines I mentioned before, protection after the first vaccine and before the second is probably about 50%. And efficacy is maximum 2 weeks after the second shot. Why do I want to get vaccinated? You want to protect yourself. You want to protect your family. You want to protect other people. You want to protect Western Mass, and that's called herd immunity. This is kind of a little bit of a difficult concept to understand, but say you go into a community with 100 people, and then one person walks in who's got COVID. If you didn't respond to the vaccine, but the other 99 people in your community did, the chances of you getting COVID from the one person who walks in is really small. You have to really come into direct contact with the other person, spend a lot of time with them. On the other hand, if only 50% of the people in your community are protected, the person who walks in is going to affect a lot of other people. They're going to spend time with you, and you're much, much more likely to get infected. Another reason to be vaccinated is be a role model. If you get vaccinated, your neighbor's more likely to get vaccinated. You can really help our community. Some schools, I don't know if colleges are going to allow students back next fall. If vaccine has been distributed enough, if they'll let kids back. If they haven't been vaccinated, I don't know what the public schools will do. And some workplaces may not be excited about people coming to work who haven't been vaccinated. There are concerns. I think the biggest is that, this is new, and that's understandable. In terms of very serious reactions, anaphylaxis, it's only been about 1 in 100,000 folks who've received the Pfizer vaccine. The numbers for the Moderna have been 1 in 200,000, maybe even 1 in 400,000. This is new vaccine technology. We don't have any other vaccines out there that are mRNA vaccines. But again, as I pointed out, the genetic material there in the vaccine doesn't get into the brain of our cells. It doesn't get into the nucleus, and it's gone in hours to a day. We don't know how long we're going to be protected. There's a good chance that we may need boosters down the line. This is a better vaccine than the flu vaccine where we get shots every year. But in general, if you get a coronavirus like common cold, they feel immunity wanes after about a couple of years. We have seen, though, that people who've gotten coronavirus seem to have a significant level of protection for at least 3 months, maybe longer. And we're not quite sure how good the vaccine is going to be against the new strains, but we do know so far that it's done a great job about keeping people from getting severely ill with the new strains. There's some really good videos. Depending upon our attention span, if it's 3.5 minutes, there's a nice piece out of Boston Medical Center. Dr. Fauci and others have put on a 6-minute video. And as I mentioned, or I don't think I mentioned to Stu, but San Antonio put on a vaccination town hall too, very similar to ours, and theirs runs about 45 minutes. For those who like written materials, here's something from my employer, Mass General Brigham, and there's also a nice fact sheet from the New England Journal. And thank you. Scott, you want to unmute yourself and start? Michelle, could you help Scott?
There we go. Thank you so much. I really appreciate that. I apologize for the delay. I could not unmute myself. I want to welcome everybody. And I do have the chat open, and you're welcome to put additional questions in there. I have a series of questions. Some are from the chat, and others that are prepared. So feel free to add. So let me just start with some of these questions for Dr. Granowitz. First is, why do we get a second dose of vaccine, and what happens if I don't? And I think you answered this a bit, but how much protection do you get after the first dose, and then after the second?
That's a really good question. I'm glad to answer it again. So in terms of the vaccine, the thoughts are you might get about 50%, maybe a little bit more protection after the first shot from the Pfizer and Moderna vaccines. But again, it depends upon how long you wait after the vaccine too. You know, the longer you wait, if you check too soon, you don't have much protection. The second shot, it kicks you up to 95%. I think folks, really should get both unless there's really been a very, very serious reaction to the first one.
Thank you. So the next question actually is, you mentioned side effects, including your own experience, but the other thing we've heard about is allergic reactions. And can you comment on how common these are, and what people should do if they've had anaphylaxis, either to food or other substances or to vaccines in the past?
Sure. I just want to go back and add a little bit more to my previous answer, if that's okay. If you've gotten the Pfizer vaccine with the first shot, get the Pfizer vaccine with the second shot. And the same
right.
with Moderna. Don't mix and match vaccines. We don't know what would happen there. Allergic reactions to the vaccine are extremely uncommon. Anaphylaxis is about 1 in 100,000 with the Pfizer vaccine, and between 1 in 200,000 and 1 in 400,000 with the Moderna vaccine. In terms of reactions, there are 2 products that you have to be careful of, that if you've had a reaction to before, that you don't want to get this vaccine. One is called polyethylene glycol, which is the predominant product in Miralax, which is used for constipation, and also in Go Lightly, which people take to get cleaned out before a colonoscopy. And there's a second product called polysorbate, and that's in some vaccines, including this one. And the reason we worry about polyethylene glycol is that it has similarities with polysorbate. So if you've had a reaction to a vaccine, or if you've had a reaction to Go Lightly or Miralax, then you really want to be careful about getting this vaccine. And you should talk to your primary care doctor, and they may want to send you to an allergist to be, further evaluated. Depending upon where you are, there's some increased level, some groups have increased levels of concern of people who've had anaphylaxis in the past. For example, I have one. My mother saved my life when I was 5 years old. I had anaphylaxis to a bee sting. So in some settings, they are monitoring people longer. When you get the vaccine now, at least in our neck of the woods, people are being monitored for 15 minutes because between 85 and 100% of the anaphylactic reactions are occurring within 15 minutes. But people who have had anaphylactic reactions in the past, either to bee stings or food or drugs, they're being watched for 30 minutes. But that's varying from site to site and state to state. Did you have any other questions there, Scott?
So yeah, so as far as the allergic reaction, if you're concerned about this, especially if you've had a history, would you recommend taking anything prior to going to get your vaccine?
It's a great question, and I don't think anybody knows the answer to that for sure. Personally, I would not. I don't think you want to suppress your immune system in any way. In a sense, having a reaction is a good thing. It's called reactogenicity, and it tells you that you responded to the vaccine. So I wouldn't want to suppress my immune system at all. That being said, I do think it's reasonable if you notice that you're getting some reaction, or if you're very trepid, to take Tylenol. Whereas aspirin, ibuprofen, non-steroidal anti-inflammatory drugs can suppress the immune system because they're anti-inflammatory. Tylenol doesn't do that. Acetaminophen, the other name for Tylenol, is a good analgesic. It fights pain, and it's good for fighting fever, but it doesn't suppress the immune system. It is not anti-inflammatory.
Thank you. So there's questions about people who may be excluded from getting the vaccine. Can you comment on vaccine for pregnant women who are considering being pregnant or who are nursing?
Okay, well, I think there are three different groups there. So I think if you're considering getting pregnant, I probably would hold off for a short while, around the time you get immunized. If you are pregnant, there were some women who did get pregnant who were in these studies that I mentioned before, and they're being followed now. So far, we haven't heard anything untoward happening to them. The vaccine should not affect the fetus because, again, it doesn't get into the cells and integrate itself into our genes. It stays separate from our genes. So there's no expectation that it would. On the other hand, as we mentioned before, it's a new vaccine. So I think a lot depends upon your situation. If you're pregnant and you're a bus driver and you've got to go to work every day to put food on the table and you're going to be exposed, I think there's a very strong impetus to get immunized. If you're someone who can stay at home full time during your pregnancy and not go out, then I think the need to be vaccinated is less. That being said, I still think the vaccine is probably very safe, but I just can't give a guarantee. In terms of nursing, I think the risks are very low, and there might be some benefit actually, because if some antibodies are produced by mom and they're transmitted to baby via breastfeeding, it could be beneficial.
All right. I will add, as a pediatrician myself, an experience from flu, which I would extend here and just say that vaccinating moms markedly protects their babies who are too young to be vaccinated. And so I certainly, when this is asked of me, I certainly encourage a discussion with the mom's doctor, own doctor, but see it as a protective measure for their baby. How about immunocompromised patients, someone who's on chemotherapy or has another immunocompromising condition?
Actually, I want to follow up on the point you made, Scott, which is
okay.
a good one. The state has put out a list of what it considers comorbidities, which are going to move people higher on the list to get immunized as we move from group to group. And one of the approximately 10 diseases listed as a comorbidity is pregnancy.
Oh.
So now to go to your new question, which is immunocompromised. If I was immunocompromised, I would definitely get vaccinated. The chances of having a reaction because you're immunocompromised are no greater than someone who isn't immunocompromised. In fact, they may be less because your immune system isn't as potent. The problem if you're immunosuppressed is you may not respond to the vaccine as well. So the vaccine may not be as efficacious, but I don't think there's any increased risk of harm.
And let me just follow up there. Many people who are immunocompromised or either by their illness or by medication they take are told not to get live virus vaccines. Are there any of the COVID vaccines live virus vaccines?
The two that are available now and the Johnson & Johnson, which may be approved soon, none of them are live vaccines.
All right. Let's see. So some questions specifically about vaccination, about the vaccine. Is it possible, I think you answered this, but is it possible to get COVID-19 from the vaccine?
Scott, by the way, I think re-answering some of these questions is a great thing because it means it's a really important point. And no, you cannot get COVID-19 from the vaccine.
And can you comment again, because there's additional questions just on side effects from the vaccine?
Sure. Probably over half of folks are going to get soreness at the site. That usually lasts from 1 to 3 days. Many people, well over 50%, are likely to experience similar symptoms to what I had: a little bit of headache, achiness, little feverishness, kind of malaise where you just feel punky. And again, that generally lasts less than a day, at most a couple of days, 3 days. The Johnson & Johnson, what I've read, I haven't studied it as much because the vaccine's not as available, but what I've read, the side effects are relatively similar. There have been an extremely rare number of people who've gotten the Moderna vaccine who've actually had swelling of their arm about a week later, but again, self-limited. And as we talked about before, the risk of anaphylaxis is less than 1 in 100,000 with the two vaccines.
Thank you. So two-part question. Does it matter which vaccine we get? And I guess along with that, a paired question that comes out of the chat is, am I likely to have a choice as to which vaccine I get?
Well, I appreciate the chat question because it kind of answers the first question. I don't think for a while we're going to have choices. And my advice to you is get it. There are, I think both the Moderna and the Pfizer vaccine seem like they're dynamite vaccines. We may have to get boosters over time to protect ourselves against waning immunity or against the variants, but they're a great start. The numbers are a little bit lower for Johnson & Johnson. As I said, that may be simply because of the group in which it was studied. But again, I wouldn't turn down the Johnson & Johnson vaccine if it was available to me. I would get it.
Thank you. Are there any long-term complications expected? Obviously, we haven't had these vaccines for a particularly long time, but is there anything from what we know of the technologies and experience that we have?
Great question. I'm actually going to go on a tangent first. I have seen a number of people who have miserable long-term complications of COVID. So even though some have died early, it seems that many people continue to feel poorly for a prolonged period of time. I've seen some patients who can't work 8-10 months. As hard and as much as they want to get back to their jobs, they can't. I've seen young people who couldn't go back to college. What people tend to have is they can have persistent shortness of breath if they exert themselves, persistent headache, persistent brain fog, persistent muscle aches, weakness. It's just awful. And so a lot of young people, say, well, I'm not going to die of this. And they're right, the chances are extremely small. But at the same time, if you get this, what's called long hauler syndrome, it's awful. We are not aware at this point in time, nor do we suspect that there would be any long-term sequelae of these vaccines. But that's one of the concerns about it, is it's new, and this is a new technology.
Thank you. Do we have any idea, do we have any sense as to how long the immunity will last? And I'll actually add to that and ask whether there's an effect of the variants on kind of the answer to that question.
Great question. We don't know how long the immunity will last beyond 3 months. We know for sure it's 3 months. It probably is longer. As I mentioned before, we do know that with the coronaviruses that cause the common cold, general immunity there lasts only about 2 or 3 years. Your second part of your question again, Scott, could you repeat it, please?
Is how do you foresee the developing variants affecting our expectation for how long this lasts and our need for booster doses over time?
That's a great question, and I think we will. I think, as I mentioned before, is if you've gotten the vaccine, it is theoretically possible that you can get infected but not feel ill, so that you could still spread the virus, which for you means you're personally protected, but it kind of diminishes that benefit of herd immunity. So I think we will I think there's a reasonable, probably a good chance that we will need boosters in the future. And the companies are already working on boosters that do a better job of protection, complete protection against the variants. Remember, the vaccines out there do a great job about protecting you from getting in the hospital or dying from the variants. But obviously, it would be great if it could completely prevent infection.
All right.
The joke I heard is that, nothing's perfect. Even Tom Brady doesn't win the Super Bowl every year.
Okay. For people who have had COVID-19 infection already, should they be vaccinated, and when should they be vaccinated if they should?
Fantastic question. So we know from the studies that were done that some people got COVID, like right before they got the first injection or got it during the study. It doesn't seem to be any untoward events towards them. We also know on the flip side of the coin that if someone is infected, it looks now like you have pretty good protection for 3 months. The standard recommendation is that if you've gotten COVID, you should wait at least until your symptoms are gone and you have gone beyond the standard quarantine period that we have for people who have COVID-19, which, depending upon who you speak to, could be anywhere from 7 to 14 days. If you're immunocompromised, especially if certain cells called B cells in your body are immunocompromised, there you could excrete virus for a very long time. And the answers to those questions people should ask their doctor.
And then just as an extension of that, if your infection comes after your first dose, should you get that second dose? And is there an expected timing for that dose?
That's a great question. And as of now, the general suggestion is, again, you wait until you are asymptomatic and it's been and you're past the quarantine period, and then to get it. We just don't know how well the vaccines work if they aren't, either the standard 3 weeks apart or the standard 4 weeks apart. And we do have some evidence that it's not going to cause harm to get the shot if you've had COVID. But again, that is one of the unknowns.
And then how about for people who, is there any different for people who were treated with antibody, convalescent plasma, or remdesivir?
Yes, well, so what Scott's mentioning is these are some of the available treatments now. Remdesivir is a drug that acts against viruses. And there was one study out that suggested that it was beneficial by shortening duration of illness in people who had the infection. There should be no problem in someone who's got remdesivir for them to get vaccinated. On the other hand, if someone's received plasma or monoclonal antibodies. The reason you would get plasma is that it has antibodies in it. And then these antibodies kind of work in place of our immune system. Well, the problem is the good thing is they can help us, especially the monoclonal antibodies if given very, very early in infection. The downside of it is that if you get injected with a vaccine, they can bind to the proteins that are made as a result of the vaccine and prevent them from stimulating our immune response. So at present, it's recommended that if you received either plasma or a monoclonal antibody, that you'd wait 90 days before getting vaccinated.
So, so some questions about how we go about life after vaccination. So can you describe, you did a bit on this. Can you describe what herd immunity is and how the members of the community being vaccinated help create this herd immunity?
Sure. I hate to repeat myself because if I didn't communicate well the first time with the analogy, I'm not sure the second time will be any different, but nothing else pops in my head now. So say you're with a group of 100 people and the other 99 people in your group are all protected against COVID, but you're not. If one new person walks in the community with COVID, the chances of you getting it are very small because that person would have to come in direct contact with you and they would have to spend quite a bit of time with you. On the other hand, if the rest of your community was uninfected, that new person coming in could affect them and they could affect you. And so your chances of getting sick are much higher. That's herd immunity. Herd immunity is when you got the other 99 people who can't get disease. So even if you're susceptible, you're protected. It came actually from the idea of the wildebeests and lions, is that the wildebeests, when they're attacked by lions, they bring the young and the elderly into the center of their pack. And they're the vulnerable ones. And they're protected by the stronger wildebeest who are on the outside encircling those who are more susceptible.
Terrific. So after I'm vaccinated, will I still need to wear a mask in public?
In our country, a lot of this hasn't been law, so it's been left up to people at times. Now it seems like there's more of a movement towards, at least in public places, requiring people to wear masks. My answer to that is until we have herd immunity, I think people should keep wearing masks. There is going to continue to be spread. You don't know if you're going to be protected. And as we talked about, you could get infected, be asymptomatic, and then share it with your family. You don't want to do that. So I think we're going to be masking at least till the fall. My hope is that and I have secondary gain here because my daughter will still be in college. My son's graduating. But I'm hopeful that they'll be able to get through almost all the population, especially the college population, by next September. So that when kids go back to school, both college as well as grade school, high school, that they'll be immunized by then. I think once we have that, we can start talking about not wearing masks.
Can you comment on travel after vaccination? And there's specific, of course, in this community question about travel to Israel and whether that is special with Israel's experience in particular.
Well, it is special. Just to go to Israel is special, having been there a number of times. They actually have immunized a much higher percentage of their population than we have right now. But travel is an issue. These are really challenging questions, and in many ways they come down to personal decision and how much risk someone is willing to tolerate and how much risk someone actually wants to take. Risk is defined as two things. It's the likelihood that something will happen, and it's how bad it's going to be if it does happen. And both of these are at play here. The chances of you getting infected are obviously a lot less if you're immunized. The chance of you getting really sick are a lot less, but they're still there. There's also the issue of you can still spread to other people. Personally, I'm not traveling now. I don't want to bring that back to the hospital, for example. And so, I'm not doing that now, and I have been immunized, and I am wearing a mask. I don't wear a mask if I'm out in the woods by myself, but when I go to the supermarket, I wear a mask. I want to protect others, and I want to protect myself. But, in many ways, this becomes a personal decision. We had millions of people travel around the holidays, and, that resulted in millions of more cases of COVID. Part of the way that China was able to restrict the spread of disease in the country is they had a very strong lockdown about people traveling.
So let me take some from other sources from the chat and elsewhere. Can you comment on those with autoimmune disease and the risk and benefit from being vaccinated for those who have autoimmune disorders?
Yes, that's a good question. And I think the best place for folks to go there is to ask their rheumatologist. I would start there and ask them how they feel about it and get their expertise. They know your particular illness. They know you, especially, most importantly, as a person, and how your immune system works better than anybody. And I would go to them for advice. Theoretically, there shouldn't be an issue. But again, you're stimulating the immune system in someone who does have autoimmunity. But it is not considered a group that we would not give the vaccine to. But again, people have to, individualize.
And can you comment, the WHO did its review on Wuhan. I haven't seen this, but there's a review that they reported. Can you comment on what the WHO reported?
Well, I read it very quickly. I didn't read the full report. What I found most interesting was something I mentioned at the very beginning of the talk, is that they feel that the virus spread to people, not directly from bats, but there was probably some intermediary host. So I'm not quite sure how that affects our lives, but it's a point that's interesting. It's very similar to the other SARS viruses. MERS in Saudi Arabia, went through camels, and there's probably a civet, which is a cat-like creature in Southeast Asia. That probably was involved in transmission of SARS-CoV-1 from bats to humans.
All right. So my final question for you that I got is kind of like lightning round here. Having answered all of these individual questions, the big thing is that for our lives, there's kind of multiple pieces that all go together, and I think everyone's trying to do this. So I'm going to ask this question that came to us. I thought really kind of puts it all together. So let me just read this question. My children and grandchildren reside in the Boston area. School vacation for the grandchildren is coming up, and we want to go visit them. We want to go stay with them during their school vacation. The grandchildren are, young school age. They attend elementary school, and they have class that's in person through the pandemic. One of the parents works from home. The other works in a hospital setting. The parents and we have some have been fully vaccinated, others partially vaccinated, others not vaccinated, and certainly the children are not vaccinated. We've arranged testing for before we travel. If we test negative in this situation, is it safe for us to do this? Safe for us to go to Boston and stay with the children and grandchildren?
It's such a great question. And at the same time, it's such a difficult question to answer. Let me start with the testing. So the testing is potentially 70 to somewhat higher % sensitive. So, and it depends upon which test it is. and one should be able to get that information. And so that's a starting point. But obviously, if the test is a PCR, it tends to be more sensitive. If it's an antigen test, it's less sensitive, and that may even be less than 70%, the antigen test. So that's the first place. That's one place to start to answer the question. But obviously, all these issues are intermixed. Children are very frequently asymptomatic and can carry the virus. We thought that schools were a big place that children would get infected. It's turned out to be an important place, but it's not as great a risk as we thought it would be. But that risk is generally being assessed with families where, the parents aren't in their 60s, 70s, and 80s. The parents are, in their 30s, maybe their 40s. So, that's a piece of the equation too. I'm a little concerned about anybody who is, over the age of 60 and is going to be exposed in a household to people, to family who are at higher risk of getting infected, not likely to be infected, but at higher risk. I would be a little concerned about going into that situation. I would feel more comfortable doing it if I had been vaccinated. I don't know if personally I would still do it myself with my parents. They're in their late 80s. But I think it would make me more comfortable, and I might be more willing to do it if I had been fully vaccinated. If I wasn't, I would be really kind of concerned about that. But again, Scott, I'm a conservative person, and everybody has their own tolerance of risk. I've had a cousin of mine die of COVID. I watch people die, in the hospital, and I've had people come back with long hauler syndrome. And so, I'm seeing some rough stuff at times. It's very relentless, and I tend to be, and by nature, I'm more conservative. But there's some things that aren't good, and there's some things that are, debatable. One thing I would say is if the folks do go and go and help their children with their grandchildren, I think they should be masked. I would wear masks because that really can minimize. There was a new paper that just came out today that suggests if you can get the mask to fit tighter, it's even more protective. Or if you double mask with maybe something of nylon that's over, say, a surgical mask, that would provide more protection. So, there's no perfect way unless you are unbelievably wealthy and you just stay in your house and you never go out. There's no way to eliminate risk. All of this is mitigating risk and minimizing it. And in the bottom, there's some things that aren't okay, but most other things, there's a lot of gray, and everybody has to decide for himself. So no, would I go into that situation if I was 75 unvaccinated? I wouldn't. Would I say it's wrong? No.
So let me ask just one additional piece. So if you're talking about someone, let's say someone who is vaccinated, so someone who's 75, they're in the group that's able to be vaccinated, but we've heard so much about the potential of being infectious, even if you don't get sick. Can you comment on being fully vaccinated and going into kind of another, entering another pod and the risk of bringing infection post-vaccination?
Yeah, well, I can tell you that from my own life is I'm vaccinated, and my parents still don't want me to visit, and I respect that. And I think it's a good decision. We're going to have a very interesting discussion when we're all vaccinated. Just like the audience member who asked the previous question. And obviously, we don't want to keep doing this forever. That makes no sense, because then we take all of our joy out of life.
Yeah.
But again, once we reach that herd immunity, it really makes things a lot different, because we're a lot less likely to be exposed. Our kids are a lot less likely to be exposed. Our grandchildren are a lot less likely to be exposed. And then we're a lot less likely to share it amongst ourselves.
Okay, and then two quick ones that I realized I missed from the chat. One is, do you have any insight as to when in Massachusetts, it will open to the next group, which will include 65 and over and those with comorbidities?
Yeah, they're hopeful by the beginning of next month. And that would be, I think it's 65 and 2 comorbidities. And I have from my partner, if you'd like, I can read what those other comorbidities are, if people would like. Would that be useful?
Yeah, I
Sure.
think that'd be great.
Okay, good. Let me just find it here. Okay. Cancer, chronic kidney disease, what's called COPD or chronic obstructive pulmonary disease. That's emphysema. Down syndrome, probably because people with Down syndrome do oftentimes have cardiac problems, heart problems, heart conditions, heart failure, coronary artery disease, people who are immunocompromised, like we talked about before, people who are obese, people who women who are pregnant, as we mentioned before. I don't think any men who are pregnant would probably be on the list. Sickle cell disease, smoking, and diabetes, which is just a major risk factor for so many diseases. So there'll be people who are over 65, have 2 comorbidities. They're going to be the next group.
And just one quick addition to that, are you going to need a note from your doctor indicating that you have these comorbidities, or are you going to be able to just assert that you do?
Oh, that's a great question. That's going to differ from location to location. Some are going with the honor system and some are asking from letters from doctors. It's going to be quite challenging for doctors' offices if they have to provide letters for everybody. But it's going to differ we were finding now it's different from place to place. It's not even statewide in some places. It's just community to community, immunization site to immunization site, depending upon who's overseeing that site.
Right. And there's a question about teachers. I believe teachers are in that following group. Is that correct?
Yeah, let me see exactly where they are. If I can read it. As I get older, they get smaller and smaller, and these are tiny slides. Okay. So they are the group after that.
Right. The next one.
Yeah.
Okay.
I mean, they're talking about heroes, teachers, nurses. I mean, these folks are just amazing, amazing. What they're doing. And I take my hats off to them. They're so brave.
And then one I skipped over. I'm sorry for the person out there who asked. You mentioned about anti-inflammatory and the risk and the issue of trying not to suppress your immune system in advance. How about after the vaccine, especially if you have symptoms? Can you take Advil?
That's a great question, and I would really. I went 5 weeks. I didn't take anything. I do think it's very reasonable to take Tylenol. I would be very careful of aspirin. I'd be careful of ibuprofen, Motrin. I'd be careful of taking an antihistamine. All of these things affect our immune system. On the other hand, if you take these and you need them chronically, then it's a discussion with your doctor. I still think it's worthwhile to get vaccinated, but you're running some, and no one can tell you how much risk that you may not respond like that 95%.
Okay.
Okay.
Yeah,
Well,
thank you.
Thank you very much. I'd like to thank Dr. Granowitz and Dr. Siege for being here with us tonight. And I want to make sure that I do tell you that the doctors who are with us this evening are not representing their organizations. They are here to help answer questions for the community, and we greatly appreciate that and thank them very, very much. So thank you, everybody, for being part of this call. And as I've been saying a lot lately, please stay safe and healthy.
Stuart,
and have a good night.
Another thing.
Yes, please.
I'd just like to say I admire everybody here who's come to listen. It means that you're engaged, you want to do the right thing, and I think that's just awesome. Thank you for your interest and your commitment to helping each other.
And thank you again. Thank you very much, everyone. Have a good evening.